get started. I'm filling in for Dr. Lupu today, who's away at a conference. So today our speaker is whom we all know, Dr. Michael Wilde. Dr. Wilde is an internal medicine physician by training. He's also our Vice President Medical Officer at Sanford USD Medical Center. Dr. Wilde completed his undergrad degree at Creighton University and moved back to South Dakota for both medical school and residency here at University of South Dakota. He's been active within our internal medicine department since 2002 and was promoted to a full professor in 2017, and is going to talk to us today a little bit more about systems-based practice. So welcome, Dr. Wilde.
Okay. Thank you. So we got a few online as well, so welcome all those as also. But really what I'm going to talk today is my role as a medical officer in an organized medical staff. And when I'm talking about physician issues, I would say it's fairly applicable to other disciplines as well. And really what I'm going to start, how I'm going to start is just an overview of how we all got here. And so from a systems-based practice standpoint, so this is not going to be earth-shattering medical knowledge, and I'm going to get to this formula that I wrote down here really to make a point. And so I was going to offer extra credit if anyone can tell me what this is, but I have no credit to offer. So you'd get just my admiration if you can figure it out. But anyway, really want to go through kind of a history of an organized medical staff. Why and I'm going from a perspective of I take this for granted, how we all got here, how I'm able to walk into a facility, see patients, work with patients, things like that. And how does that all work? How did that all get set up? How does this all happen? And so you have to go back in history to really the turn of the century, not the 2000, but 1900. So turn of the century, especially in this part of the United States, if you think about Mayo, if you think about Johns Hopkins, Michigan, NYU, places like that, they were just kind of getting their start in medicine. Europe was getting its start in medicine because there wasn't much medicine. We were starting to get aspirin, we were starting to get surgical techniques, we were starting to get recognition of bacteria and their role in pathogenesis. Pharmacy stuff would have been a heck of a lot easier with aspirin only. Of course, probably would have had a shortage of that too, but anyway. And so there wasn't just a lot to offer, but what was starting to happen is, of course, people were moving out of the little villages and becoming more urban. And so larger communities were starting, and larger communities sat around and had sick people. And what did you do with sick people? Because people got to a point where they didn't necessarily want to have them in their house. Technology was advancing to a point where some places could have something to offer. And what do you do with sick people? So those that organize a community kind of sat down and said, we need a place for them to go. And thus the birth of hospitals. And if you know the history of Sioux Falls, it's the, I think it's Woods Fuller is one of the first hospitals in Sioux Falls. It's the law office on 14th and Phillips. That was actually one of the first hospitals in Sioux Falls. And if you think about it, it was kind of right on the suburb of 14th Street there coming up out of downtown. And so that was a place for, you didn't have to deal with icky stuff in your house, and you could take people who are sick. And then, of course, if you have a place where sick people can go, you start to attract people that can take care of them. And that's all well and fine, great, but all of a sudden people started to think, hey, there's schools out there that train doctors or nurses, but what does it mean to be that specialty? What does it mean to be those people? And we kind of need a stamp of excellence on, yes, this is legitimate, or no, it's not, because what was happening at that time is there was starting to be a movement of reputable schools, especially on the East Coast and moving toward like Michigan and Iowa. but there was a lot of other schools out there that weren't necessarily up to par. In fact, it was just some folks getting together, kind of talking about things and stamping a degree. And there wasn't training in what was considered a formal curriculum, and that started to develop as well, because a need arose. Because if you think about it, in a situation like that, why wouldn't you just open your shingle as a medical school, say you can train people, collect their money, and kick them out with their degree? And why would another school say, geez, if I work really hard, do a bunch of research, come up with a formal curriculum, develop faculty, et cetera, why am I doing all that work when a guy out there can do the same thing and they're all considered the same? So a need arose. And again, medical discoveries are kind of hastening that progression as well. But the real need is patients needed to be cared for. So I think a big revolution that occurred was probably World War I and advances in surgery. And then there was a little illness that occurred at the end of World War I, which are coming right off the 100-year anniversary of that, and that's influenza. Influenza was not known at the time as to what the cause was, and so there's tremendous research in a very short amount of time, and it identified universities that could really work on something of that nature and do it properly. And they would go around, travel around, and look at the various other schools and deem some as reputable and some as not. And that was, in my opinion, kind of the start of an organized medical staff. So what was happening then is you had these community hospitals that would take in patients, care for the community, and the community hospitals were starting to have people show up at their door saying, I can take care of these people. I got my medical degree at the Ned Brown Frontier School of Medicine. And the community was like, great. And then they kind of realized what the product was, no offense, Ned, from the Ned Brown School of Medicine, and they realized, not so great. So then these guys from Johns Hopkins, guys from Mayo, the Mayos went and started that place in Rochester and then built it up, and it's like, well, these guys actually can do it right. And we need to be able to kind of get a seal of approval on these folks from these medical schools to say, yeah, you're legit and can work here, or no, you're not legit. So that was kind of the start of our early process, which has led to modern medicine, where we're at now. And where we're at now, of course, is providers working in hospitals and providers having a seal of approval that they can work there. And I always use the example, what's stopping any of us from getting in our cars, driving to Minneapolis, showing up at the U of M, and being like, hey, I'm Dr. Wilde, I'm here to take care of patients, and what's stopping us from doing that? And what's stopping that is a credentialing process. And that's that seal of approval. So as regulation developed here, federal regulation, state regulation, and then we'll talk about some other guys called the Joint Commission, they started to say, you know what, if you're going to work, the public we serve has told us that we need to license you as providers, and that's not necessarily enough. You actually need to then be credentialed to work in the various facilities. Otherwise, you can't work there. So you need your credentialing. So all of us are licensed to provide something in the state of South Dakota, whether it's be pharmacy, social work, medicine services in the state of South Dakota. We're all licensed because we have to be in order to work here. You can certainly work here without a license, but if you're caught, that's obviously going to be a big problem. In fact, ruin your career, because this will never happen to you. So why isn't a license sufficient for you to take care of patients? You need a license, but does a license allow you to walk into a facility and take care of patients? No, it doesn't. You still need to go through more of a process. I always use this example. I'm a licensed physician. I still work because I have gone through this process. I still work as a hospitalist. I have a sister-in-law out in Fort Collins, Colorado, who is licensed in the state of Colorado as a physician, radiation oncologist, who hasn't seen a patient since 1996. she's licensed. And licensure includes, lack of felonies, good background, graduation from a medical school, a reputable medical school, and completion of a residency program in good standing. That's licensure. Great. Okay. You don't want to, most of us, I think all of us would agree, you don't want a radiation oncologist who has last seen a patient in 1996 providing radiation oncology services to you in 2018. So there's the difference between licensure and credentialing. So credentialing has more stringent criteria. And credentialing, so let's back up here a little bit and see, and just kind of set how this all works. So we have hospitals all across the United States, and these hospitals are governed by the federal and state governments because, again, the people got together and allowed these places, most of them not for profit. So we're going to give you some tax advantages to take care of our sick and those in need, etc. You can make a buck doing it, but we also expect you to take care of those in need. And then there's for-profit hospitals that may cater only to a certain population, orthopedics, heart, things like that. And we're not going to talk about those so much. We're going to talk more about the not-for-profits because that's a more common facility in the United States. So you have a hospital that serves a community. And a hospital by law, and this is where I'm just going to trust me on this. This is all I know because if you ask me to explain it further, I can't. But this hospital is governed by a board. And this really applies to most places you go in America. So Sanford, Avera, Nebraska, Texas, all these places are going to have a hospital that serves a community, and it's run by a board. It is not run by the president. It's not run by the CEO of the health system. It's run by a board. A board is set up so that it represents the community, because again, we're serving the community, therefore it's run by the community. Typically, we'll have some providers that provide services at the facility as well. That may be nursing, that may be physicians, that may be pharmacy, it doesn't matter. You typically have a little bit of representation of those working in the facility and those served by the facility in the community. So that's the board. What happens below here is really up to these guys. It's not up to the federal and state government. So the board usually sets up a structure because these folks don't know the ins and outs of running a hospital. So they usually will have a president, and then the president will set up a structure below him or her to run the facility. And really the only ask of the board is have the place open, have it financially stable so that it doesn't all of a sudden leave us in the middle of the night when patients are in need. So have it open, have it nice, do a good job, take care of patients. That's all we ask. And so usually this guy or gal is like, man, I need some help. So I'm going to have a leader of medicine, nursing, operations, HR, and then you see all the titles: patient experience, quality, pharmacy, name it. Doesn't matter. It's just whatever this person feels they need to run a facility. And then, of course, you go into like vice presidents, executive directors, all the titles. None of that is required by regulation. What is required is that a hospital have a board, and the board is obligated to the city to keep the place open. So my role, so we're going to take this M here and move it up here. So we have the board working with the pres, working with these folks. So medicine. So what happens here is they say, okay, we're not comprised completely of physicians. You're probably not a physician because physicians aren't smart enough to run all the other HR operations, finance, etc. stuff. So we need you to run the medical staff and make sure that they do a quality, safe, patient experience, friendly, clean, you name it. But you ensure that the patients are taken care of, because I got to answer to these guys, and if they're not taken care of and these guys are at some cocktail mixer in the, and someone comes up to them complaining about the facility they're on the board of, I'm going to hear about it, you're going to hear about it. Okay, so I got to make sure that I have my stuff together. So one of the first ways that I make sure people are safe to work at our facility is we credential them. Have you done medicine somewhere in the United States? Well, first off, are you of sound mind and body? Are you free of felonies? Has anyone else gotten rid of you because you're not a very good provider? Did you train? Did you train at reasonable facilities, or did you go to the Ned Brown School of Frontier Medicine? No offense, Ned. No. Have you worked somewhere in the last couple of years? Your past places you worked, did they like you? Didn't they like you? Those are all the things that go into the credentialing. 99% of the time, everyone is perfectly fine. 1% of the time, they might be fine, they might not. And that's where I spend a lot of my time, and that's where I ask my fellow physicians to sit on committees to help me determine if these folks should be working here or shouldn't they. So that's the credentialing piece, and that's something you all go through no matter what facility you go to. So what stops you from going to the University of Minnesota and saying, I'm Dr. Jarvis, I'm here to take care of patients? The credentialing process. You can't put an order in, you can't do anything because you're not recognized by that medical staff. So, but you can work at Sanford because we've recognized you and you do just fine. So you leave here, you go to the University of Minnesota, you're going to go through a similar process. They're going to check with us to make sure you did okay. They're also going to check, you're also going to get several binders of things to sign and fill out. And those are all forms that you need to fill out so we can do our credentialing process. One of the things that you will hear about, and I'll just make mention of it here, is what's called the National Provider Database. Anyone heard of this before? National Provider Database. Excellent. So the National Provider Database was, of course, built out of need, and it was a federal system. So federal government got sick of hearing about, God, Sanford had this really bad provider. They said he was great. They sent him to the University of Minnesota. Turns out he wasn't great. They sent him to the University of Indiana, where he allegedly killed 3 patients. And we're really sick of hearing about that. So we're going to start a system so that facilities can't pass their bad apples off to other places. That's the National Provider Database. If you wind up on the National Provider Database, you will most likely never be able to be credentialed. Unless for the one reason you can wind up on it, and that's a malpractice suit. If you have a pile of them, you might have an issue, but 1 or 2, probably going to be fine. So you do wind up on the National Provider Database if you have malpractice suits. Otherwise, you wind up on the National Provider Database if you really kind of screw up. And basically, when you screw up, your credentials are pulled from you by a facility. A facility will say, Dr. So-and-so, you did a poor job taking care of this patient. You showed up, high on drugs, you whatever. We're going to cut off your privileges. You cannot walk in this facility. We are then obligated to tell the National Provider Database what we did, and good luck getting hired somewhere else, because part of the credentialing process is to look at the National Provider Database, and you can't have a report on there. So just to be familiar with the National Provider Database, so it's something that came out. Of course, no one wants to be on it, so if you're ever going to wind up on it, you're probably going to wind up in a big lawsuit for many years. because you will have your career ruined and you're going to fight for your career. So kind of a spooky place to be, National Provider Database. Usually they literally do wind up in a decade-long lawsuit if there's an issue taken. All right, kind of a little aside there. So one of the ways I ensure quality and safety is through peer review. And I want to educate physicians about this. So you're credentialed, you're on the medical staff. So one of the ways that providers are allowed to look at the care of other providers and do it safely, think of this as a legislative gift given to us by the federal and state governments. Every state has governing legislation on peer review. The federal government has legislation on peer review. It's a way for providers to talk with each other about the care of patients and not have it discovered by the courts. So what happens in a malpractice case is if there is a patient that feels like they were wronged, their attorney will query all of the pertinent emails, phone records, everything else, medical records, trying to get at is there a wrong or not. So let's say in a situation where I'm taking care of a patient, Dr. Jarvis comes in and says, oh my God, you don't take care of community-acquired pneumonia this way. You really didn't do this correct. And he emails all of his buddies, sends a couple of text messages, tells a couple other people. Number one, I can sue Dr. Jarvis for slander. Number two, if the patient I cared for comes after me, there's going to be a lot of information, and Dr. Jarvis is going to be right in the middle of it as to, Dr. Jarvis, tell us why you said all these things. So what's a good way for Dr. Jarvis to look at my care? It's to submit it through peer review, because peer review is not discoverable by attorneys. It's in a box that is a gift from the federal and state government. So peer review allows us to look at each other's care and not have it wind up in the courts. But there's some rules that go along with it. You don't want to email, text, or publicly report any of the information. You want to keep it within the peer review process, because once it gets out, it's discoverable. So if Dr. Jarvis and Dr. Mahesh are part of a peer review committee, but they talk to Dr. Brown about the case, and Dr. Brown's not part of the committee, Dr. Brown could be liable to give testimony to that. If they talk to Dr. Larson, who is part of the committee, that's perfectly fine. If they send it in email to Dr. Larson, that could be discoverable. If they send it to via paper, it's not discoverable. So in this day and age of electronics, I have to hound people to send stuff via letter. It gets challenging from time to time, but that is peer review. And why I want you to be educated on peer review, because any institution you go to is going to have a peer review process, and it's going to seem weird, it's going to seem oppressive. You're going to wonder why people are asking questions about your care. Respond as you're instructed in writing in paper. And really, the intent of peer review is to better the patient care. Remember, quality and safety of patient care. It's not to get you. The intent of peer review is to make you a better provider. But because of the regulation that goes around it, it can get very oppressive and challenging. If you get a letter from a peer review committee, you assume automatically you did something wrong and they're coming after you. They're not. They're trying to educate you or just find out more about the case. Because sometimes the medical record doesn't tell it all. Okay. So I talked about, because I looked at my objectives here, define and educate about an organized medical staff, credentialing of providers, and then peer review. So now let's talk about, we talked about those accrediting agencies and how we get stamps of approval. So as part of the medical staff, we have a board, we have a president, we have people here and here that all help to run the facility. You go through, as providers, you go through your credentialing, you go through your peer review process, You're working on the medical staff, that's great. So who comes around and says, okay, board, president, physicians, nurses, pharmacists, case managers, you guys are just doing great, we're gonna keep paying you. Or we're gonna tell the government to keep paying you. And so we're always subject to survey. Someone's always looking at us, because remember that board is responsible to the community, which is part of the state and federal government. So really the federal and state government comes around and looks at your facility to make sure that you're following the rules. And that you can keep your doors open and that you're doing a decent job for the community that you serve. So CMS is the federal government body that controls healthcare, Centers for Medicare and Medicaid Services, CMS. They work very closely with states' departments of health. Between the two of them, they answer to us as the voting public to say, and we've looked at these facilities, they look fine. Remember Yankton, the mental health hospital in Yankton got closed down recently. IHS, I'm blanking on if it was Rosebud or Pine Ridge, shut down recently. Who shut them down? These guys did. Because they found unsafe practices and they have to answer to us as the voting public. The best way to see how surveys are going to go or what you're going to be looked at is simply to watch the news. If you watch the news and you see medical stuff going on in the nation, chances are these folks are going to start looking at it because constituents start talking. And you can just see, the things that we work on really hard, things like sepsis, things like patient experience, wait times, readmissions, things like that. Those are all things that Congress people are hearing from their constituents about. And so their method of dealing with that is to say, hey, CMS or at the state level, Department of Health, go look at these guys. What are they doing? Classic cases, I'm getting old now, but if you heard of Joan Rivers, who was kind of a comedian in the United States, passed away during an upper endoscopy, I believe, in a surgery center in New York City, Manhattan, I think. I would venture that that's where a lot of our sedation monitoring has come from, because it was felt that was an anesthesia-related issue. And that was kind of right about that time where there's a tremendous lens right now on sedation. Pharmacists will remember the cases a couple of years ago of the contaminated epidural injections and the regulations that went on around that. It really just have to pay attention to the news to know where these guys are going to go, because that's what their constituents are going to talk about. They got sick of hearing about, boy, that place is a crap hole, they're rude to me, blah, blah, blah. That's where patient experience is coming from. Anybody can say anything to these folks at any time, or your Congress people at any time, because we're all voters, and so we can do that. So the regulatory bodies, and they have rules that we have to follow. Otherwise, we can't keep our doors open and we can't get paid. So we have to. It's not a, no, we have to. And they survey us to that. So then who are these guys? You've heard of the Joint Commission? Sanford people can't answer that. You've heard of the Joint Commission. So the Joint Commission is a private company that facilities pay to come in and survey them. I always remind, anytime I talk to surgeons about the Joint Commission, that the Joint Commission is by surgeons for surgeons. So, The Joint Commission can be a challenging organization to work with, but frankly not as challenging as these folks. So the rationale for the Joint Commission, and there's a few other companies out there, I can't even remember the names, but really what they have said is, we all know federal and state government, they try to do a lot of things, try to be everywhere at once, but can't quite pull it off. So out of necessity, companies like this started up and said, you know what, we'll do this for you. That way you guys don't have to do it as much. And that's really how that started. It was back in the 1950s. Some surgeons got together, tired of doing surgery, and said, you know what, we're going to go around to facilities and see if they're good, bad, or otherwise. And between the two of us, we're going to come up with rules and then decide if we agree on them or not. And it's kind of interesting to watch it, because as you watch the literature, these guys and these guys don't necessarily get along, and they don't agree on the rules. And you know, it's kind of funny, because ultimately these guys hold the key to these guys, because if these guys say, you know what, we're not going to work with you or take what you say, these guys are out of business. We'll all cancel our contracts. But at the same time, we'd all kind of rather work with these guys. So it's kind of like there are advocates and our adversaries at the same time. So what the Joint Commission does, the Joint Commission, per these organizations, have what is called deeming authority of healthcare facilities. So they can come in and deem that a facility is worthy of participating in these programs set up by CMS and the Department of Health. These guys, and I'll take my surgeon comment back here just a little bit, these guys actually kind of are by physicians for physicians, or by nurses for nurses, or they're by providers for providers. So they have to prove to these guys that they're doing a pretty good job looking at you, but they try to be a little more reasonable, rational about it. And so we set up a contract and we pay them dollars. They deem us. But at any point, these guys can come through our doors too and survey us. Because think back to 1900, 1920. How do we know that this facility is worthy of being in our community? What's out there to tell us that? Well, it's all these guys. So while it certainly can be burdensome and can get picky and can get regulatory, it actually is to our benefit and to the community's benefit, because that way when the community complains about an issue, it's like, hey, we're doing everything we can. And we all know that we get complaints from patients to these guys, unfortunately, fairly often. It really helps to have worked with them and to know that we have been given the seal of approval by their companies. And so those are the regulatory agencies that you'll typically see. So let's go back to CMS. So CMS sets the rules to have your doors open and to get paid. You have to follow certain rules, hit certain conditions in order for them to pay you. And when they pay you, they set the precedent for all the private health plans out there. So whenever we talk about, we're getting reimbursed, 1% less from CMS, that's not only CMS, that's going to be every health plan out there. They all have use CMS as the template or the precedent to do that. So we pay a lot of attention to what CMS does. Now, from a systems-based standpoint, and I'm just going to move quickly here to really kind of the end of what I have to present, because I'm going through a lot of stuff. And if you internalize some of this, you'll already know more than 90% of the physicians and other clinicians that you work with. And I think it's halfway reasonable information to have. So when you work with these guys, does anyone, you guys can't answer it, does anyone know what this garbage is I wrote up here? Nah. Yeah, I mean, if you do, you need help. So what this is the 2018 CMS Prospective Payment Systems for Hospitals. So down here is your paycheck. Simple, right? I have it right here. It's a summary. It's a 13-page summary of a couple hundred-page document, and the formula is right here. And what goes into this? And so I'm going how they set a wage, because you guys are all going to get paid, and want to get paid. How does that all work? Well, those guys really set the curb and gutter. And it's all kind of based on this. And this is for inpatient, not clinic, but inpatient. So basically what all of this says is you get paid based on how sick the patients are that you take care of, how well a job you do taking care of them, where you live in the country and your cost of living, and then some random numbers here that I don't know what the hell they are. But if you look at it, where do you live in the country? Geographic adjusted rate. How sick your patients are, that's right here. They actually double weight it. Readmissions, don't want readmissions, so that's in here. Hospital acquired conditions, we're not going to pay for complications. That's your problem, not ours. We're not paying for it. So that's all in here. And then you put it all together and you get dollars to you. Every year, the Affordable Care Act really made some changes to this formula. And every year, they take the geographic adjusted base rate, they take these percentages, and they move them around just a little bit. There's a lot of debate that goes into that. And again, what it does is it sets the precedent for all other payers out there. In general, last year, this equaled a 1% increase. 1% for payers or providers. What does that mean to you as a physician or a pharmacist or anything like that? What it means is when you're sitting there, and this is not meant as a heavy-handed statement or a threat, I just think it's kind of fascinating when you sit there and you look at, God, I wish I could get, an extra 3%, or surely, I did a good job last year, I should get 5 to 6%. It's not as simple as dollars from a payer to your pocket. It goes through a lot of stuff, and there's just a lot of stuff that goes into it, and a lot of complexity. So the bottom line as I talk about all of this, and really I think my take-home message is have an understanding of, a little bit of an understanding of the complexity of how a dollar gets to your pocket, how you get on the medical staff of a facility, what the facility entails, because you'll hear about the board, you'll hear about the president, you'll hear about CMS, the Joint Commission. What is the take-home message to you? And that is that stuff exists. It's part of a systems-based practice. No matter where you go in America, you're going to have to practice by it because these guys said you have to. If you follow the rules, do the most important thing, which is do your best to take care of patients to the best of your training, all of this stuff very nicely will take care of itself. And what I mean by that is, yes, it is burdensome when the Joint Commission shows up, when CMS shows up, when you go through things like this for your negotiations and all that good stuff. But at the end of the day, and I've worked with enough providers now, that the 90% of them that are dedicated to the care of patients and like to be physicians, they like the science of learning. I still work as a physician, but I like the science of finance and regulation and things like that, which God help me, but I do. And so you're always kind of learning. As long as you show dedication and passion to that, you're going to be just fine. when providers start to step out of that box and they start to really get consumed by things like this, or absolutely burdened with these guys and fight it, or they are not dedicated to patient care, knowledge, or advancement of their knowledge of medicine, or they try to cut corners, or they fight the accrediting agencies, that's when you wind up in trouble. And that's probably 10% of people on every medical staff in America. And so the take-home message for you is have an awareness of this, but simply take care of patients and you're going to do just fine. So that's all I wanted to talk about and cover today. So we talked about, to end there, CMS and the Joint Commission and their roles, and I think you're familiar now with all the terms you need to be to really get you started and actually function pretty well. Are there any questions at all?
Touched on the National Provider Database. What types of things are actually reportable to that?
Excellent question.
If there's a general answer, I guess.
There is a general answer. All right, what gets you kicked off the National Provider Database? Malpractice suit. Whether it is won by the plaintiff or settled. Dismissed from medical staff. So whether it be peer review or a behavior issue, something like that, the medical staff just says, we don't want to work with you, get out of here. Leaving a medical staff. During investigation. And this is a formal declaration by your partners in practice. They say, Dr. Larson, we are going to investigate you. That is a formal declaration, and that means you should be working with a lawyer who should tell you, don't leave that medical staff right now. Just wait till this finishes. Those are the three things. This is, of the ones, this by far is the most common. This is the next most common, and typically what happens is people don't realize they're under investigation. They don't understand that investigation is a big thing. And I've actually seen this at Sanford, not that we've done it to people, but have had providers that were like, it turns out I left a place during an investigation. I had no idea, and he's on the database. And oh, by the way, the provider has the right to sue the medical staff to not be charged with this, and they don't want to wind up on the National Provider Database, and that's where you wind up in courts, because they will appeal. Good question. Question back there.
So you were talking earlier about, essentially, quote unquote, fighting or whatnot, raising a ruckus with CMS and Department of Health is not good. But how do their recommendations or rules, do they ever change? Do they ever get updated? And who's the people that do that? And is there a way that you can kind of coach them or kind of help the general process?
Good question. CMS, even though it's fun for me to demonize them, CMS is comprised of generally healthcare providers and then lawyers to guide us, because we don't know what the heck we're doing when it comes to law stuff, and that's really what it comes down to. So they survey. They go out and look at healthcare facilities. It looks like a best practice. They're human. Looks like a best practice. Looks great. God, we are seeing that in all these facilities. We should have a rule about that. Man, did you see that case in Montgomery, Alabama? Now all of Alabama's talking. Now I got the senator breathing down our necks. We should probably have a rule about that. Those are the ways that they kind of come up with rules. And then they also have to, of course, have a budget. And as you can imagine, they're not pouring in loads of money into CMS's budget to pay us more. So, okay, we got to respond to Montgomery, Alabama. We got to respond to some stuff we're seeing in survey, good and bad. And we also have to cut out $1 billion. And so about every year, or as needed, they will kick out proposed rules. And then we can comment on them, and then they kick out a final rule. And that's really what this is. This is a summary of the inpatient final rule for 2018. It also changes with the flavor of the administration in charge. So with the Trump administration taking over in the last couple of years, we have had a patients over paperwork mantra coming out of these guys. And they made some big proposed changes for this coming year in terms of reimbursement, documentation, medical student documentation, things like that. They're working for us as constituents, but they also have to try to do it from coast to coast and border to border. And it's not easy because we're all a little different, as this formula attests to. So it's a challenging role, but it's providers, some are in practice, some aren't, but they're human. Other questions?
The top board positions, are those all like a voluntary position, or is it more like a full-time paid kind of position? How does that work?
It's a voluntary position. So Sanford's board, for instance, right now is the dean of the medical school. 3 physicians on the medical staff. A gentleman that owns a steel company, a lawyer, business owner, coach, realtor, and they want to be part of the board. I mean, it's kind of cool. Mm-hmm. Got a lot of, a lot about a cool organization. You say the same thing about Avera too. And so it's voluntary. Plus, especially if you're in a business role, to be able to kind of that's a resume builder. I was on Sanford's board. That's kind of cool. Anything else? Good. I always offer at any time, if you see me walking around the doctor's lounge, things like that, not you guys, but hit me up if you have questions. I'm happy to take them, because you might run into a form or see something and be like, what is this? And it's kind of interesting stuff, so happy to chat. Otherwise, thanks. Have a good day.